Hello, this is Jonathan Yunis from Sarasota, and I've been asked to discuss strategies for optimizing data entry into the ACHQC as a private practitioner. I think the most important issue in entering the data is to really appreciate the potential benefits. Just imagine if all of your variables of your previous surgeries had been entered perfectly over the last 5 years, as well as your outcomes. The value to the surgical community as well as to your own outcomes would be amazing. Obviously, that's quite ideal. The other thing in private practice, I am working toward a relation with academic colleagues as I am in many ways alone as a hernia specialist. I am very close to my surgical colleagues, but is by being in the ACHQC database, we certainly are overlapping. Also, I think I have an obligation to contribute data as a single surgeon. This is quite valuable going forward. Also, we often get from patients the question of, hey, doctor, what's your recurrence rate? And this is often difficult to answer if you don't have the exact data, and it would be nice to be completely transparent with accurate data. Also, the choice of operation is a big frustration in my practice. I know even though I have become facile with open, laparoscopic, and robotic procedures, it is often very difficult to know what is the best possible way to recommend for a particular patient. The other value is to kind of see where you are on the curve. I'm always pushing myself to get better, and I'm also very active and do quite a bit of surgery, as you can see here. Other tips and tricks. Obviously, the front office staff enters the demographics at the time of the booking, and you would also want to enter your data as soon as possible after the surgery, and to actively memorize the workflow of the data entry. What I mean by that is I noticed after a while that I was looking backward and forward, but the more I concentrated on memorizing exactly the sequence of questions in the database, the easier and more accurate was my data entry. Most importantly, you got to get one of these, a really smart, motivated physician assistant, and do everything you can to motivate them and optimize them, pay them well, engage them in the office, teach them everything you know. But it is important for me to frequently review the accuracy of the data that she's entering. I have to keep her on task. We discuss it a lot. And you got to remember, if the data is not put in accurately, that old saying of garbage in only reveals garbage out. So we really want to make it very accurate. So what about entering data for follow-up? Well, it's pretty obvious that you want to organize your office follow-up to correspond to the QC follow-up. 1 month, 3 months, 1 year. And also you want to enter that follow-up data when they're in the office and as soon as possible, so you don't forget to do it and the accuracy is proper. So the greatest weakness in my practice is the follow-up data, as well, I'm sure, as many of your practices. And one of the interesting things about follow-up data in the office is that we tend to record only problems because they stand out. We have some selection bias onto who gets recorded. When I see a recurrence or other complication, we tend to enter the data, but for long-term happy patients and a busy office, we often neglect to enter these happy patients as the denominator. The ACHQC database, everyone knows, you can be looking exactly where you're at a moment in time. I do believe that composite hernia recurrence and um, patient outcome described recurrence, patient reported outcome, is clearly something that is likely to be lower than the data I'm recording because, again, I am recording every complication and certainly have been very lax at recording long-term results with patients that are happy and have had no recurrences. Similarly, with the patient-reported European Hernia Society composite, I think that myself, as well as my patient's response to the emails to complete in the long term about the quality of their surgical results, has been far from perfect, and I'm motivated to improve that. For those people that really are entering data, it is very important to realize that the European Hernia Society in 2012 met and published the guidelines for data follow-up of ventral hernias in the journal Hernia. The European Hernia Society quality of life score is a method to measure the quality of life for patients before and after the surgery. And they specifically wanted to look at pain at the site of the hernia repair, restriction of activities, and cosmetic discomfort. That cosmetic discomfort likely it needs to be translated in a different way due to some confusion, at least among my patients. And that you recognize this is the data from the original paper in 2012, and it's very important that we all stay consistent with these questions so we can be comparing notes. But at the same time, I think it needs to be rewritten somewhat because I think there's some confusion in my patients about, if they don't bike ride or they don't play sports, it's just a little vague that they have to check that X outside the box. Also, my patients find this particularly confusing, and I've discussed this with several people where it's asked, what about the shape of your abdomen and just this concept of cosmetic discomfort. Maybe that can be changed to cosmetic satisfaction. But in terms of the shape of the abdomen, one of the big issues that we find is that the patient often has extraordinary amount of visceral fat and or pannus, and that even though the surgical repair area looks excellent, the shape of their abdomen to the patient might still be cosmetically ugly, but I'm not sure how that reflects on a well-performed cosmetic repair of the hernia itself. In the second line, where we're looking at the side of the hernia and the scar, that is much more specific about the cosmetic appearance of that. However, certainly we see confusion in that a lot of the patients don't even remember which side their hernia is on or where the actual hernia was. So I'd be looking for several things in the future, and what I'm hoping for is a phone application which is optimized page by page. And I think this is important, even though I know it's expensive and we may be far off from it, because myself and maybe many of you were restricted in access of the internet or off-site sites in many locations in the hospital, and it's just easier if we could do it on your phone. And similarly, it's not easy for me to run around the hospital carrying a laptop. The other thing I'm hoping for is an enhancement of the inguinal database. Specifically, I want to be looking at the different techniques and just as we do in ventral hernias, where we have robotic, laparoscopic, retromuscular, etc., that if we can really have that filter on the inguinal side, we can have a much more easy query of the data that you can do yourself as opposed to asking help from others. And similarly, I think it's important to have a unique database for umbilical hernias and epigastric hernias because We still find the management of these quite controversial, and it is a little difficult that they're mixed in with the ventral hernias because they're completely different, and also they don't have to be quite as extensive of questioning for small umbilical hernias. Another idea that I'd suggest is that we encourage surgeons who are entering data to use a caliper in the operating room to accurately define the size of the hernias, especially small umbilical and epigastric hernias. After you after you start looking at what size they are, most primary umbilical hernias are 1.5 to maybe 2 centimeters in diameter. And if we're really looking to match up the diameter size with the optimal outcome based on the optimal operation, um, a few millimeters might make a difference, and it'd be better that we're not estimating, which many of us likely are. The other confusion that I see is in sporting activities, the frequency and severity. I think this is very important. When I see athletes, I feel significant more pressure. I'm sure as many of you as well feel this, because these people are in touch with their body, they feel things, and they need to perform. So I think it should be entered on everybody with every hernia, but it should be two separate things. The frequency of the exercise, are you doing it once a week, twice a week, every day, twice a day? And then the second piece of data would be the severity, meaning are you a world-class triathlete, a weightlifting competition, or you just ride a mile around your community development for 1 or 2 times. So ultimately, I'm recommending that we enjoy every moment of the surgery and to accept the small inconvenience of the data entry. And to remember, it's a privilege to be a surgeon. And the effort of data entry for outcome enhancement, I think, is an obligation.